Beautiful. Okay, guys, this is actually exciting. I did not create a syllabus for this. I thought we can start very simply with how we're going to start our shift, the different parts of the tracker, if anybody has questions, and we'll move on from there to doing some orders on somebody, picking up a patient, doing orders on them, following a patient's journey. We can then, if we have time, do something like sepsis advisor, and we can do something like mental health, chemical restraints. We can do some documentation. And I don't want to keep an eye for hands up. So if you have a question, just jump in, unmute yourself and start asking. So this is the tracker. We've talked about this. This is ED launch point. I've made these smaller. The tabs at the top are where all the pods are. And each one of them, let's take pod A, for example, you have buttons here that filter out the patients. You can select to only see my patients, so I don't have any patients right now in pod A. You can filter just unassigned. You can see if there are any empty beds, on and off. Critical results, you can add the waiting room to this. Most of the time, you'll only go to any of those to pick up a patient. So if I'm working in A or I'm working in RAS, I go to RAS, I want to see unassigned people, and I'll pick up my next patient. And then once I do, they'll show up in my patient list. And from there, I'll work with them all the time. Reassessment is where the patients also show up when there's a reassessment. The checkout button is for people who have been discharged or are related to you. That's where you can see them at the end. I don't have anybody now because it's empty. On top here are several buttons that are links. This is ED launch point. And these are other things like message center, tracking board, calculator. Try to use exit when you're exiting, just so it doesn't keep the session open. If you open a couple of sessions, and there's a maximum of 2 or 3, I think, and you don't hit exit and you don't save it, those will stay suspended in the background and you won't be able to log in anymore under your own login. There's, of course, a fix for that, but we don't need to worry ourselves with it right now. Here, you can add links that you like to the internet. So I've added ER docs here. And in my video that I did last night, you can see I added CNN. So you can add whatever you want. Not that I'm recommending you add CNN. Where we start, I'm going to turn this into full screen right now. And where you're going to start when you start your shift is to check in. This is called the hamburger menu. Who wants to play me and check in? Does anybody want to try it? And I can give you control.
I can try.
That is Yusra, am I correct? Did I hear
Yeah.
correct? Yusra, where are you in my system? Are you?
It's Ridal.
It's Rabab. Oh, I'm sorry, Rabab. Okay, Rabab. So you should be in control of my mouse. Can you try it? Perfect. So you're going to go up and click on the hamburger menu, and you're going to click check in. Or check out. Oh, I'm already checked in. Can you check me out? Okay. Just hit OK. So you're going to walk into apartment not checked in. So check me in. Hit the hamburger. Select check in. And now that's my name. There's my initials, my relationship, my role, my default site, and my color. And now I'm checked in. So now let's go pick up a patient. How about we go to pod A? It has 7 patients at the top. Even higher? You got it. So now what we're seeing is the patients in pod A. You can sort them out by clicking the column. So you can sort them out by name, you can sort them out by acuity, you can sort them out by length of stay at the end. I want to pick up, let me pick up roadshow in 19. So before you pick up A19, oops, my dictation started. Sorry, I'm going to turn that off. Okay. So this is the one I want to pick up. But before I want to pick up, we usually like to read the triage note and the vitals, right?
Yeah.
So you can get there in a couple of ways. You can click under the name of the patient in the empty space there. You want to do that to live? I think you're still in control. Great. So that opens up this window that has all the information you need, right? So in the first column, you're still in control. I'm gonna move with you. Level 2, penicillin allergy. Any critical notes? There aren't any. Previous visits are here. Triage, you came in with a headache, presenting complaint headache. These are the vital signs. Now, Rida, do you
Yes.
see where it says triage subjective assessment? Patient complains of. Move your
I have triage information.
down, yeah,
Triage,
perfect.
yeah, okay.
Put your pointer a bit lower over patient complains of and leave it. And there you go. And now you can read the triage note. Yeah, my pointer is big because I'm old.
Yeah.
Yeah, if you leave it there, so triage subjective assessment, patient complains of headache for 5 days. I'll move it here for you. For 5 days, denies vomiting, intermittent blurry vision. You can do the same here for the objective assessment, uncomfortable, grimacing, skin clammy, date and time. You have home meds.
Is the text going to be the same size in actual?
Yes, it does not follow. Yes, it does require a little bit. Now, I have a very big screen with a high resolution, so that's why it's also showing a little smaller on your screen.
Okay.
And procedure history. Now, if you look at the top here, look at these buttons. I'm going to close this. Do you see those? They're the same buttons, right?
Mm-hmm.
If you click any of those, you go back to the exact same window. It's just, this is the patient. These are the vital signs. These are the medications. These are the tests, the lab tests. This is the ECG. This is X-ray. This is patient care orders, and this is consultations. So you have so much information right here. Now, let's see. Okay, Rudolph, you're going to sign me up, and then I'm going to hand over to somebody else. So to sign up, you're going to close this.
Close.
Yep, you can hit the X
Just
at the
click.
top. Here, yeah, there you go. Click. Perfect. Now, do you see those columns? I'm going to bring you over that here. This is where you have the doctor's name, the nurse, MPPA resident, and ED tech. This is the physician. So I want you to click where the physician is. So you click on a different patient. You want to sign up for Chloe? We can sign up for Chloe, no problem.
Oh, sorry, no, I can do
Okay.
that. Just give me 1 second.
Although I think I've ordered a ton of things on Roadshow. Now you open the chart because you clicked on the patient's name. I'm going to close it for you. So you need to click somewhere here.
Mm-hmm.
And now just click assign because there's no MD. And now the patient is mine.
Mm-hmm.
Okay. Now what I'm going to do, who wants to play a little bit more? Who's next?
I can go next. Can I ask you a quick question first, though?
Absolutely.
So in a situation where there's multiple MDs working on a patient, for example, a trauma with G5s and multiple people,
Beautiful.
does everybody sign up?
Yes. So let me try to find someone who signed up for a doc. Here's what I can do. I can take A16, okay, and I can assign him to another doctor. Let's see who's in the system. These patients are on the system. I'm going to assign him to Tim. There you go. So Tim is here. Oh, Tim signed up for another one here. Look at that. I can sign up as well. And if you notice, this looks like a stack. That's me and Tim behind me. And if I hover, it shows me who they are, right? And when we're done, if I'm leaving it with Tim, I just unassign myself and it stays with Tim. Now, here is something very, very important. Okay, can't download Zoom, working on it. No worries.
Sorry, Rafi, everyone can assign a patient to everyone who wants? So
Yes, you can, of course. Right now you can. You just don't do it. You didn't know how to do it. But you can. And every tracker you can. This is how we hand over.
Yeah, but okay. You don't have to go through the handover process. You can just assign
You're supposed
the
to.
patient.
You're a professional. It's not the computer that
Mhm.
stops you from doing that,
Okay.
right? You're supposed to talk to me before leaving a patient in my care. Yeah, so it is very important to sign on and off. Do not talk about any patient without signing on. 2 reasons. First, if there's no PIA, you've just captured a PIA. Second, most importantly, just by signing on and off, now this patient is going to end up on your billing report when you print it at the end of the day, so you can bill them. Third, because you signed on and off when they get discharged, they go to your checkout tab, so you can find them again. So for a lot of people, this is going to be a big change. We don't talk about a patient without signing up. So here's what I'm going to do. Now that you've mentioned that, no, we'll do it later. We'll do a ECG later. So
Rafi,
now
just a quick
go ahead.
question. Are you going to record this session? Is it going to be
It's
recorded?
being recorded, yes.
So can you distribute to us
Yes.
after we're
And
done?
I'm going to put it on YouTube.
Okay, thank you.
Okay, Ryan, I think you're in control. Did I give you control? Maybe I forgot.
No, it looks like I can, but I don't know why it's not moving. It says you can control Rafi's screen.
Okay, there you go. Now, because my pointer was in my other screen. Try now.
I'm trying.
Oh, I lost it.
Doesn't want to work.
Oh,
Okay, let me
is
try
that
to do
working?
it. Let me try to stop giving you control and then start it again. Stop control. And I'm gonna, Ryan, you're next. So now we've read the note about the patient. We've looked at their vitals. We have signed up for them. Are you in control, Ryan? You should be.
I think so. Is that moving the pointer?
No, you're not moving my pointer. No. Oh, there you go. Now you're on.
Okay.
So now let's go back to my patients because this is where I work, right? Now here's our patient. So what do you want to do next? Do you want to see what's happened to him, what results we have already on this guy?
Sure.
Perfect. So there you go. If you hover, it'll tell you whatever's ordered and the status. So CBC has been dispatched, vinyl mandemic acid has been dispatched, blood urine nitrogen has been completed. If you click and open it, these are the results. Now, here we get to
Rafi,
last orders from the tracker.
will this be populated with old Meditech labs when this goes live?
No, this is visit specific.
Okay.
So these are labs from this visit.
Current encounter. Okay.
When you open the chart, you're going to see something else.
Okay.
Okay. So now let's talk about shooting an order right from here. Okay. You can reach orders, as you remember, from anywhere. You'll end up in the same spot. I highly discourage you from venturing into orders that we have not worked on as the ED team because the urgency might be incorrect. The tasking might be incorrect. They'll go to somebody you don't want them to. Like, for example, if you order an ECG on the floor, it's tasked to the tech next morning. So if you use that order, you'll never get your ECG done. So let us look at this. And how about you pick something and order it? Lactate? Beautiful. Now notice how it went up in my green box here. Click the green box. Sign or sign and close. Now from here, you cannot modify your orders unless they require a mandatory field that's missing. If you sign, it'll shoot directly. Let's see. Shoot. Gone. That's it. You just ordered the lactate. Because it did not require any questions of you, I just shot it back. Now, let's read an X-ray report. Want to go to X-ray? Beautiful. So we have a CT without, and we have a X-ray. These are blue, so they are ready. Let's open one of them and see what they look like. There you go. That's how the report opens.
So in terms of PACS integration, are we still just opening PACS separately or?
No. So here's what happens. If you don't have a report and the exam is done, if you click this, it should take you straight to PACS. to that specific patient.
Okay, what about when we do have a report, but I want to look at it anyway?
Is there a button that, oh, see, this is cert, it might not have all the buttons, I don't know.
Okay.
We do
I
have,
don't know.
sorry, just to interject, Rafi, there is a button there because from the training, there's a button that says that you can go in and view image in one of those icons. It's just really small for me that I can't see, but if you press on that, like if you hover over it, it will say view image.
It's
and
right
that will
here.
take
Yeah,
you
but it's
into-
grayed
yeah,
out because we're in cert.
yes, in real life, it will take you into iPads.
There you go. Thanks, Ben. Beautiful. So let's close that. You can exit from there. Yeah, okay. Same order applies here. Let's go to ECG. So, oh, we opened the patient chart now. Let's go to ECG. Now, what will happen in life is the ECG is going to be here. When you click on the ECG, it should take you to the viewer. And that's where you'll put your wet read. There are no ECGs for me to show you. The system does not have ECGs.
So when you say this is where you'll put your wet read,
This is where we're at no STEMI.
do you have to hit like add up here?
I've never seen it before.
Okay.
So I don't know.
Fair enough.
We're going to figure it out day one. Okay. So these are the things that you can see in the tracker. You'll do a lot of your work in the tracker. You can order a lot of stuff in the tracker without even having to open the patient's chart. But now we need to open the patient's chart to start playing a little bit. So before that, while we're about to go open this patient's chart, the triage nurse calls, and now there's no paper, right? They're not going to come, and says, I want you to look at ECG for a patient. So who wants to play this role? I'm going to
Can
take
do.
control. Sorry, who was it?
Was me, Ali.
I missed it. I couldn't hear you.
Ali.
Oh, Ali. Okay, Ali, where are you? Ali, here you are. So Ali, you now have control of my screen. Try it out. Sometimes it takes a second.
I'm clicking on ECG, it's not opening.
No, because you're not moving. Okay, let me see now yet. Try to move again. Because
I'm trying, but your cursor is
you're
on.
moving your pointer, but you're not moving mine.
Yeah.
Okay. You are in control, Ali. Let's try it again. You want to give it one more try? Let me do the same thing I did with Ryan. Stop sharing. And then give you sharing again. Let's see.
No. Maybe try someone else.
Okay, let's try someone else. Who wants to go?
I can try Rafi.
That is
Craig. Sorry.
Craig.
Yeah.
Okay, let's see if you've got this, Craig.
I'm not using your mouse yet.
No, you're not. Apparently, he's not as reliable as one thinks. Come on. Okay, so it's not a problem with Ali, it's a problem here. Oops, I stopped sharing instead. Look at that. I hit the wrong button. I hate it when that happens. Okay, maybe remote control will work better now. Okay, Craig, you've got remote control. Let's try.
Still no.
If it doesn't work, you'll just tell me what to do and I'll click for you.
No, it's still your mouse is still not following mine.
No, it's not following.
I would have clicked on that thing that looks like an ECG, right?
Okay, so first, let's do this. Let me take control. Okay. So first, the patient's in the waiting room, right? So we're going to try to find the patient, right? And she say, I got an ECG on this guy, on waiting room, Mr. ZZ test, baby Sam. And that's the ECG. So what are you going to do first?
Click on it.
No. What are you going to do first?
Oh, sign up, sign up.
That was the trick. So you're going to sign up. You're going to look at the ECG. You're going to view it, right? You're going to write your wet read. You're going to go back. And she ordered already a directive, let's say. But say, you know what? I also want a BMP. You're going to sign and close. And now what you gonna do?
Now I'm gonna look at it. Wait, sorry.
Okay.
Now
Now
I'm
you're
gonna.
Now you're gonna sign off.
Oh, okay. Yeah.
So what happened now is that patient got signed to me. I accessed their chart, and remember, notice I accessed their chart. I gave whatever orders I want. We picked up any idea how to get audio to my AirPods. That's Riddle, sorry. Connected, but only audio through computer speakers. Click the little arrow next to the mic symbol in Zoom. Okay. So now we picked up the PIA, and what we also did is that you established a relationship. So now you can go later, it'll show up in your reports, you can bill on them, and when the patient gets discharged, you can go to checkout, it'll be there, and you can see if somebody saw him or they left without being seen.
Technically, any patient that I sign up to and sign off is going to show up on my list at the end of
Yes,
the day.
once they get discharged, they show up, oh yeah. On a report, yes, on the relationship report. That was the 3-minute video I made this morning, my latest masterpiece. Now, the other thing that you're gonna do is probably dictate a small note on this patient. So that's what I always do. I do it after the fact, I don't do it at the time. And we'll do a small note on this patient after, on ZZ Baby. I'm gonna keep signed up for him. Now, you can't stay signed up if you're gonna keep caring for the patient. If you don't sign off, it won't go back to the pool and nobody else will pick them up, right? So that's important to remember. So if you can stay
these
signed up.
will automatically go back to be seen if you unsign up
Yes.
for them.
Exactly. So because how are you gonna see them? They're gonna go to unassigned, and it's not gonna show up if you're signed up on them. Once you're not signed up, they'll go back to being unassigned. And
Quick
they will show up.
question. You have to dictate your note before you sign off, right?
No, you can dictate later.
Oh, can you? Okay.
Yeah, like very easily. I can unassign myself. I'm gonna do a quick note on this guy. I'm gonna open the chart. I'm gonna open my quick note. Just quick note. I'm gonna open my quick note. I'm gonna say 45-year-old male with transient chest pain lasting 10 minutes period, no previous medical history period. I was asked to review the ECG by the triage nurse period. Vital signs are normal period, no ST elevation period. Labs ordered. I left his care with the next MRP period.
Rafi, splitting hair here. If I sign off,
Just 1 second. So did you notice what happened? I missed dictating here because I hadn't had my cursor. If you remember, it opens this. This is the default dictation window of Dragon. You can just cut it and paste it. It was my fault. What else? I can write something like labs came back negative period, troponin is negative period, BMP was added. I'm going to sign and submit. I can change the name if I want to. Initial assessment. Sign. And that's it. That's my documentation. That's now forever in the patient's chart. And when Amber takes over the patient from me later, it's going to be in clinical documentations. Do I need to refresh? Maybe I need to refresh.
And does that now become our PIA?
That because the moment you signed off, that's your PIA. So there you go. Here's my note. ED initial ass. By the way, that was not intentional. But here's my note. And if I later, for example, the patient left AMA or, I can always add modify. It'll take me to an addendum.
Rafi, can I ask a question?
Fire away.
So let's say I see this ECG, and based on the story that I hear, I ask them to do the second probe. Now I sign off. The patient is back into the pool. It's going to fall off my radar. So who's going to be responsible, let's say, for the second probe that comes in and no one has been signed up to?
So what I tell Alexa, I do this right now, and I bill for every one of these patients. When at the end of my shift, when I'm home and I'm finishing my shift, I'll go back and see if anybody else has picked them up. And if they haven't, I will follow up on the trope. Now, the troponins, we will have a troponin tab in the results callback. We haven't gotten to, putting the process in place. But remember, your second trope is already part of your directive, right? So you should not need to order a second trope. Okay?
Another quick question here,
Yes, sir.
just for those of us that haven't really been billing while functioning as I want to call it like physician triage. So if this patient picked up and then say the MRP is billing like a G3 or something, if it's an NSTEMI or something like that. So as physician triage, what's the most appropriate billing?
I generally
for
bill
those?
a minor assessment. Look, I don't care. I bill a minor assessments of 15, 16 bucks. I bill the ECG as well. I bill those.
So if you bill a minor assessment on this,
yes,
someone else can bill an intermediate, like a multi-system?
Yes, they don't bump each other, yes.
But if someone else were to bill a minor, not that they should, they would bump each other?
Yeah, they would, but why would you bill a minor?
Oh, of course. Yeah.
Right, yeah.
I mean, I guess the situation would be if this person was called again about some result and some other doctor looked at but yeah, makes sense.
If that happened and you had seen, and I noticed you had seen this, I'll text you and tell you, here's what I'm doing with this guy. What do you want to do?
Makes sense. Cool.
Okay, addendum. The patient left without being seen, period. All his blood work was negative, period. There were no concerning results, period. I'm forwarding this to his family doctor. For example, there you go. So that was an example of what I did with this patient. Someone had a question at the beginning and I told them later. Do you remember who that was? Or did you ask your question? Okay. So now, Pam, can we go through, what does she say here? Can we go through it? And they can follow in their laptops. Yeah, okay. I will. Yes, Pam. Thank you. Okay. So I guess I was very late reading that. Okay. So this is my patient. Let me sign up for I want to sign up for somebody else because this guy, I've ordered a ton of stuff on. Let me sign up for this guy. Let me sign up for this guy. And let me sign up for this guy. There's an 8-year-old. There's not much on this guy. Good, assigned. Okay. So now, the next thing we're going to do after we've reviewed the triage note, we've picked up the patient. Generally, we're going to go see the patient, right? And when you're going to see the patient, you're going to open the chart. And to open the chart, I'm going to click on the patient's name. Now, if you remember, if you click this by mistake and open that, there was a button here that said open chart. And there you go. You can only have 2 open charts at the same time. That's the maximum. Now, is everybody familiar with this, or do you want me to go through the structure of the chart? Maybe I should, but tell me if you don't want me to. Okay. So this is called, this is called Power Chart. It has the main menu goes from left to right. The main menu is the blue menu. This is the highest level menu. The first line here is what's called M pages. These are where you're going to do most of your work, and they include different pages of different arrangements of the chart's information. ED workflow is your main patient chart. And I have arranged it the way I like it. You can bring these up and down the way you like. So I start with order entry at the top. And then I go the way I think. Vital signs, because I'm going to go into the patient, I'm going to look at the vital signs. I'm going to read the triage note, which is going to be here. I'm going to read their previous medical history, problem lists that are here. Previous visits, home medications, because that's exactly how I work. Their previous clinical documentations, if I want to read them. And I usually actually do all of this before I walk in. Do people do the same thing, or do they do it differently?
Will all the old Meditech notes find their way into this past documents?
5 years should be there on day 1, and then they'll be bringing the rest later. So we
I do
anticipate-
almost the same, yeah.
I'm sorry? Yeah, great. Okay. Now, if you've noticed what I have done on the side here, and this is what you will do in your favorites fair, is I have put actually the documentation of the patient here at the bottom, and I have moved them to the right side of the chart. And what this does, it allows me to scroll through their chart up and down, sorry, while I am dictating and typing my history and exam. Now, there are many ways you can enter this. You can type, which is fine. You can use auto text, and you can build your own phrases here. You can add something and you can call it .Rafi history. And then you describe it and you fill whatever in it and you save it, and now it's here. Every time I use it, how do I enter it? How do I send it there? I've never used it before. Does anybody know? Insert. Oh, okay, and save, no. Oh, we still haven't done that. I don't know. Let me try this again. What if I do this? And this is here. What do I do? Does anybody know how to use these? Because I don't.
I think just in the history of presenting illness, just click .Rafi history.
Oh,
over
okay.
there,
Oh, so I
and
type
it'll-
here .Rafi history.
Yeah.
You're right. There you go. Ah, there you go. Thank you so much. You learn something new every day. You are wonderful. The other thing is you can dictate, and you can dictate using Dragon. I will be building all my texts in Dragon because dictation is very easy. I'm going to test. 45-year-old male presenting with chest pain, period. Started yesterday, period. It's intermittent, period. Increased with exertion, period. Mild nausea, period. No vomiting, period. Mild shortness of breath, period. Mild sweating, period. No respiratory symptoms, period. No abdominal symptoms, period. And there you go.
Hey, Rafi.
Yes.
Rafi, did you show, I may have missed just that, but did you show the embedded, the different documentations that this system has? Like, I know that you put the dot, but before you get to the dot Rafi, we may have created the dot Rafi note, right?
Yeah.
And then
So
they
there
also
are. Oh,
have-
you're talking about the public phrases?
No, I'm talking about the notes that they have. Like they have, Cerner has embedded notes, right? Like it has all of these, like for
These
example, you
ones.
can get like review systems, yeah, in
Yeah,
that window.
Yeah. So
Okay.
so there are a few. So for example, under review of systems, they do have .ROS.
Okay, but before, because some people may not know that .ROS exists. So in order for them to know what type of
Yeah.
notes exist, they go into that window.
Yeah, this is the one. Public phrases. It is public phrases.
Oh,
So
I
this
see.
is all the phrases that are available in the system. I have to confess, I did not find them. There's 78, 79 pages of them.
So we learned something different. Can I just interject for 2 seconds? If you go into if you're in a review system window,
Yeah.
and then you see the tabs and you go to the far right tab,
Yes.
is that where you are?
Yes.
Oh, okay.
Yeah.
Interesting.
So this was my phrases. These are public phrases.
Right,
So
right.
that
Okay. Thank you.
.ROS is here. And there is .ROS ocular rosacea, documentation component. These are the public ones. I'll be honest with you, like I couldn't find .exam, for example. Did I find, was there one a .exam? So only lesion excision. .physical maybe? .phys, yeah, so .phys exam. So you could, in theory, in physical exam, say .phys. And now you have to change these to match what you found.
But Rafi, can you create your own template for different encounters?
Yes, so that's what I did. I created my own template here, Rafi history. Let me edit Rafi history. Let me change it into Rafi chest pain. Okay. And I'm going to say, what do I have here? Chest pain started on character location severity radiation what else do you do with chest pain with pain associated symptoms
Okay.
associated symptoms so now I could do wherever I am I could do dot Rafi chest pain. This will enter it here. Now, what I did is I inserted those because that one, Dragon can jump from one to the other. Next field. 2 days ago. Next field. Crushing central. Next field. Central. Next field. Severe intermittent, worse by exertion. Next field. Left shoulder. Next field. Nausea and shortness of breath. So that's one thing you can do. Or you can leave them empty and just type. You can put a colon and type. So all these are possibilities. For me,
Yeah,
I
but
have,
is there any place? Sorry, is there any place for me to create my own soap notes? Like Epic allows you to
Yes.
do your own soap note, not
so
follow this
so
form.
so you have to put in each one of those histories in the field that it belongs to. So because this is your subjective, right? This is your subjective, this is your objective.
What if I make my own soap note in the quick notes? Is it acceptable or it's not gonna be?
Put it whatever you want. So what'll happen after is when you're trying to create a note, your report, watch this, it pulls whatever you've typed in under these headings. So any way you put it is fine. It's your note, it's not mine. Like if you notice in at St. Joseph and Hamilton Health Sciences, if you read their ED visit notes, they're only like 2 lines. That's it. Like it's your note. You put in it what you want to put in it. It's not like we're not dictating what you put in it. And this is your SOAP, your subjective, objective assessment and plan. This is your SOAP note.
Raf, did you do that auto text through, was that through Dragon?
No. So Dragon, I will take you through Dragon in a minute. Yes, somebody else said Rafi.
Yeah, go ahead and I'll ask my question later. It's okay.
Okay. So through Dragon, cancel and discard changes. So through Dragon, you create it completely through Dragon, outside of Cerner. So you click this button, and all of this is in the Do You Dragon or Can I Dragon video. It's called auto text. And you see I already have several auto texts here. Already done. They all have peculiar names. So, for example, this is my current template for my dictation. This is normal physical exam. This is Rafi's anesthesia, right? So, for example, if I was here and I was to select this and say normal physical exam. Oh, what did I call it? Rafi's physical exam? Because I don't use that one. Normal full exam. Normal full exam. And that's it. My examination is there. Right? This is one I use often. This is for Form 1 patients. Rafi's Form 1. And there you go. It goes right in. So you can create them either as phrases, where Pam said here. The public phrases, I did not find them very useful, but you can create your own phrases here, just like I did. Or you can create them in Dragon and insert them right where you are. So I can do here, old anesthesia. That is my old anesthesia note. So We've seen the patients. We have done a physical and history. We've documented, and you don't have to document this, by the way, all in one go. If you want to write 2 words now and come back and do it later, absolutely fine. This is saved, but it is not final. Just make sure before you leave this, if there's something new here, you have to hit save before you refresh, because otherwise you will lose them. They're all saved. They auto save, I think, every 20 or 30 seconds or something like that.
Can I clarify something quickly?
Of course, please.
So this is the ED note. There's also the ED quick note.
Yes.
If we're seeing sort of quick interaction.
Sorry, let me tell you. So this is what you're documenting in the chart. You haven't created any notes yet. Right?
Okay.
You can put it into whatever you want. Go ahead.
That's what I was that's basically what I was wondering. So there's no matter what we do in terms of note versus quick note and so on, when it generates a note to go to like family doctors and stuff, it's going to have all these headings, whether there's
Exactly. So that's a good point to talk about the 3 types of notes we have. So we have 3 types of notes. The main note is ED note physician. This one at the top. This is that pulls everything from here and turns it into a note. Right? Once you sign this, this becomes part of the permanent record. And if I do, everything that I typed here disappears from the chart. That's it. It's been used up. Now, the other type of note. No. This card page changes. Okay. The other type of note is ED quick note. ED quick note is blank. And this is intended for any other documentations we want to do directly. Like the one we just did for the ECG patient, right? That was an ED quick note. Another good example of ED quick note is G5s, right? Right now, you would write 3 lines in the corner of the page, right? This is your 3 lines in the corner of the page. It's called an ED quick note. Anesthesia, right? This is where anesthesia goes. So here's a good example. Let me create an anesthesia note for you. And I have it like Joel wanted it in Dragon. So here's what I'm going to do. Rafi's anesthesia. Haywood. Next field. Atrial fibrillation. Next field. Previous anesthetic, no complication. Next field. 3. Next field. Negative. Except for facial hair. Next field. Normal. Next field. 3E. Next field. Successful cardioversion. Next field. Received 40 milligrams of propofol, period, no complications except for 30 seconds of jaw thrust, period. New paragraph. New paragraph. Sign and submit. I'm going to change the same into anesthesia. Sign. And now, this, let me refresh it. It does not automatically refresh so that you don't lose your work. And if you go to clinical documentation, ED anesthesia is right here. And here is my note. All done up and ready.
Rafi, is there a way to customize the layout of this ED workflow screen?
So there are a few things you can do. Glad that you asked. The first is I hide the blue menu because I didn't use it much. The second thing you do is you can pull these up and down any way you like. 3, I have these on the side here, but you can have them in flow. I don't recommend it because you generally will be documenting as you're going up and down and looking at vitals and looking at results, right? The other way you can do it is if you hit this little hamburger menu here, components, and you can remove any of the components that you like. So these are the 4 or 5 ways you can customize this. Now, you've noticed that we've been doing this in ED workflow, which is our usual day work. There are other tabs. This is the tab for discharge. This is the tab for admission. This is what's called a chronological view of everything that happened to the patient in time. Most people won't use this, so I can close it. And this is demographics. And we'll use this, for example, when we do a Form 1. You can add, there are other M pages and you can put any of these are available. So you can do a GEM workflow, ED workflow, flagged events. You can have an assessment. Let me see what this assessment M page is. Oh, that's nice. So this shows everything that's been done, labs, x-rays. Oh, that's nice. I could keep that. There you go. So these are the all different things, different M pages you can have within here. Does that answer the question?
Yeah, like when I was doing my my favorites session yesterday, we manipulated like and removed certain things. Like, is the documentation fields that we see on the right-hand side of your screen mandatory?
No, well, they're there. Where are you going to document? So you don't have to be here. I'm going to bring them all back into my documents. So this is one long document. Up and down, I can jump from here to here. And then when you want to document, you're going to go down here and say history of present illness, and it's right here. So if you don't want to cite pain, you don't have to, but you're going to go jumping. So every time here, when you're dictating, say, reassessment, and you want to look up, okay, so what was the x-ray or what were the new vitals? You're going to have to go back all the way up, find it, or go to vital signs, and then come back. While if you have them all sitting to the side, now you can document, because you have no other place to document, right?
So when we see a patient, I guess my question is like, my preference would just be to do a quick note. But
then
here we
you've
have
just
like
signed it, right? So it's okay if you're seeing a sore throat, that's okay.
Mhm.
But where are your reassessments going to go? Are you going to produce 4 documents during one visit, right?
Well, right, that's my question. So if it is something that's quick,
You
would
can't,
I
you
be
can.
entering
No,
in?
there's nothing that says you can't. Absolutely. You can type something, you can save it, and then you can go find it and edit it again. As long as you haven't signed it, you can edit it. But that's not how the system is actually fairly well designed to allow you to keep going back and forth, adding, removing. Like, even if you don't want to create your note, if you're somebody who does their notes the next morning, you still can do that, right? You fill out your documentation as you're going, it stays there saved, nothing happens to it, and they don't cross. So that's the other thing that I want to say, is that you and I could be taking care of the same patient. Each one of these is specific to us. So mine are here, yours are on your login. They don't cross. So you would do these, and then you could sit the next day, in theory, and create all your ED notes after all your results have come back. It's not a bad idea. I might do that. I might not create any notes in the ED. I might just document, and then go back later when I get home, finish these up and touch them up the way I like them, create my note and move on.
So the documentation that we're putting under these headings on the right-hand side of your screen are not published on the patient's chart for viewing for the
Exactly.
consultant.
Until you
and that
sign
kind of
it.
thing. Okay.
Now, a word of caution. You have to create your ED note and sign it, because these are not permanent and editable, which means if you don't do this and there's a complaint or there's a lawsuit and you have to pull the chart, there was no note on the visit. And even if you compile it, it is known that it was compiled as if you wrote it 6 months later, right? So it won't
this
hold.
is
What's
like
in it won't hold. So
this is like the draft section
Exactly.
for the what you sign at the end.
Exactly, perfect. Think of it as actually a scratch pad, right? You're scratching notes, and then you compile your report at the end.
Thank you.
Yeah.
Sorry, how did you move them to the right column?
This little button here. I'm going to move the last one because you can't reorganize them. They only move it. So here. So now if you notice, this should be back here somewhere. Yep, right here. So impression and plan is here. I'm going to move it back. It'll sit at the bottom. I'm going to take out EKGs and imaging. So you can do.
I just don't see those in the sandbox, so it must be.
Yes, yes. So if you remember, there are a few things that are not available in the sandbox. One of them is this button.
Okay.
You are correct, sir. Okay. So now we have documented, we've written our, let's call them scrap pad, whatever word we want to use for those. We moved on. Now we're going to do some orders, and then we're going to go do some other patient. Now, if you remember, we said you can get to orders from a multitude of places. Eventually, I'm going to open this. All orders come to live in orders. And you can add any order from here. But again, as I said, I'm going to discourage you from adding orders here. I want you to use orders in 3 different places. The first is in the tracker. So things that are available to you here. Medication, Tylenol, sign, 650 tab once, okay, done. Now, I have to confess, this is not the best way to order things, but it's the fastest way. The best way to order things is from what's called ED quick orders. You can get there in multitude of ways. The easiest is to right click on the patient, so you know it's the right patient, and you go to quick orders. Now, quick orders are here. So if I was in the ED provider view, I've always kept ED orders at the top. So if I want to add, shoot a single order from here, and there are folders here with some common orders. I don't think we have vetted these perfectly, but from here, I can quickly jump to ED quick orders. I'm going to expand them all, and then I'm going to collapse them all. So in here, what Pam, Melanie, myself, and some of you who contributed did is we went through all the orders that we think are relevant to the emergency department, sorted them out, added as many parameters to them as we can, color-coded them, and put them here. So if you are running a code, for example, or a critical case, you know that your meds are all here. If you're bradycardic, your atropine is here and your isoprenoline is here. If you have a cardiac arrest, your amur, your calcium, your epi, your mag, your sodium bicarb, your vasopressin, and a whole labs for code blue are all here in one place. If you are giving paralytic agents, here they are. There's your rock and your induction. Here's your propofol and here's your ketamine. Right? So if I want to get them to give me some propofol, I'm going to order this. And then my paralytic agent is rock. Now, everything I pick, oh, he's asking me for missing data. Who knows? Oh, it's because it's a kid. Okay. Is this a kid that I'm trying to order on? Makes life complicated. Target dose, I don't know. Anyway, let me go to another patient. Let me take them out. Cancel. Let me open another patient. Yes. Roadshow. Let's open Roadshow. And I'm going to go to quick orders. I've never tried to order rock before, so here it is. My propofol, then my rock. I'm going to go to here, and if you remember, every time you're faced with the temptation to sign an order, don't. Modify. Because you never know what you're signing until you look inside the order. So there we go. This is my propofol. And it says 40, I want 200. It's a big guy. And rock, 150. I think it calculates in the background from the weight what it wants to do. Sign. Done. The same thing applies for all your other stuff that you want to do. These are stroke orders, your types of CTs, your thrombolytics. Not that you'd use them, but they're there. All kinds of patient care stuff, all your ortho supplies, diets, your standard labs. These are your lab panels. This is where you can just pick lab DKA subphase, although you'll be using an order set, abdomen, extended lights, iron studies, overdose, simple labs, stroke, trauma. There you go. Let me order trauma. There you go. Here, modify details. I bet you it's going to ask me for an I. Oh, you see, there's a few here that are missing things. I'm going to take out this because I don't want it. Orders for signature. These two are missing. This button is your magic button. It takes it from one missing field to another. Unknown. And don't ask me why labs wants, or if they're pregnant. Unknown. Whatever labs wants, right? That's the biggest issue we have. Now that's signed. Same goes for medical imaging, X-rays, ultrasound, CTs. IV fluids, IV antibiotics. All your order sets are here. And we will do an order set. And of course, you can search for any order from here. So let's say chemical restraint. That's my chemical restraint order sets. So, what do you want to do with this guy? Should we order an order set? Because really the best place to work is within order sets.
Rafi,
How about we do that?
Is this layout customizable at all?
You can add your own. There is outstanding. There is. Oh, you have your favorites here, which is currently empty. Yes, you can add your favorites here. I don't know how. I haven't done it yet, but yes, there's a place for favorites.
In this search field where you
Yes.
search for chemical restraints,
Yes.
is this every order set available in the hospital or only emergency stuff?
So here's the thing. Everywhere you can search for an order, it searches the whole database of a few 100,000. And that is why I advise not to venture out there, because it is huge. Unless you know what you're looking for, you will get lost. And that is a problem, but it's not really a problem because that's what you need. You need to be able, as a prescriber, as a physician, to have access to any order that you want. Now, if you have access to every order that exists. So that is why you need to do most of your work either in order sets or in here. If you are stuck, you can look for something there. Does that make sense?
Yeah. Is that list of order sets exhaustive?
Hundreds of thousands.
No, I mean, in terms of ED order sets, you say, do your
so
work
we
with
have
order
thought
sets.
of everything. Like we sat there, we spent days thinking
Right.
of what.
No,
thinking
no,
of this.
I understand that. So you have this list here of order sets.
Mhm.
Are there any ED order sets that are not in this quick list of order
No.
sets?
So these
Okay.
are ED order sets. Now, if you type ED space, you'll bring up everything that's ED.
Okay. Perfect.
Okay. So let's say we want to do, what do you want to do? COPD, chest pain, abdominal pain? Let's send this patient to mental health. How about that? Click it, goes to your box. You're going to click it. Don't sign. Never sign. Always modify. Now, let me maximize this. I want you to remember this view because this is where all your orders go to live. I can close that. Oh no, it'll forget it. I don't want to do that. So the order sets work as follows. Under different titles, we have put in all kinds of things that are related to the condition you want to treat. We've only picked out a couple. I don't know why nicotine is picked up. Most of the time, you need to go and pick what you want to do. So, do I need a diet order? No, but you can. Everything that says a subphase, when you select it, it opens it, you pick it, and you go back. A subphase is a group of orders of the same type. An order set is a mixture of orders and subphases that can be unrelated, but subphases are mixtures. So they're either all diet or all medications or all patient care or all X-ray, or they're usually all labs. Now, we're giving you a Form 142. And by the way, if you click on this, it'll open ER docs. I managed to get that in. Okay. Do I need them counseling? No. Do I need this? No. Okay. So for agitation, I want them to have olanzapine 10. I can also get them to have, okay, lorazepam. Where is PO? This is sublingual. Sublingual. Oh, I don't want PO olanzapine. I want sublingual olanzapine. They don't have olanzapine. Oh, this is ODT. Yes, this is sublingual.
Raf, can I just ask you about the forms?
Absolutely.
So let's say we click on that and we get to the PDF, fill out the form 1, form 42. Like, are we still printing it?
Yes, you have to.
Okay, so
It is a legal print. So as maybe I've said before, there is something called a chartlet. So even though the patient does not have a chart, every patient in the ED and the hospital has what's called a chartlet. A chartlet is a few collection of papers that you can't completely live without. They start with a sheet of stickers, so you can label things. So every patient has a sheet of stickers. And then there are things that go with it that are still on paper. A consult from the family doc, an X-ray report from the community, papers that came from the nursing home, right? So these are going to stay in paper that eventually get scanned, but they still travel with the patient. So that chartlet is there. Your form 1 is still on paper. It's going to be printed. It's going to put in the chart. They're going to get a copy of 42.
Can we dictate
we just give that to the
form
clerk?
1?
You could absolutely, and I will show you. We'll do a form 1 on this patient. There you go. Great job. Okay. So I don't want to give them benzatripine. So we've put in the order here. If alcohol withdrawal symptoms start, SIWA protocol. If SIWA more than 8, give diazepam 20 milligrams 1 every 3 hours. Hold if sedate. So this is their, because if you order the SIWA too early, let's see what happens when you open the subphase. This is all of the SIWA subphase. It's very long. I don't care about it. So I don't use it. Oh, look at how long it is, because it's mental health. It's not ED. I'm going to turn it off. Okay. And nicotine. Let's give him a nicotine patch. Let's give him some Tylenol. I don't need any labs. I need a urine drug. I'm consulting psychiatry. Of course, here you can put other referrals. Now, notice the difference in terminology. Consult is what happens within the 4 walls during their visit. Referral is external, outside the visit. Okay. Orders for signature. These are my orders. There's something missing here. That's okay. I don't care because I have this magic button. Reason for referral is SI. Now you can edit all of these fields. The one field you might edit in consultations is the physician's name. The reason you don't need to add it, but if you do, it will automatically populate their patient list. And that way you don't have to spell their name on the phone. You don't have to send them a sticker, or you can easily. So if I was to consult UEFO, see in the system, Victor UEFO. In his list of patients with a relationship, this just gets added once I sign this. Sign.
So have we decided on what like best practice workflow is for consults? Do we do it in here and then call them?
So the order is ordered. So you put the order in, and then here's what happens. In the consult, there should be a place for the clerk to call or not, and there's a place for you to write notes. So if you've already called the patient, the consultant, just put the order with the name, and you're done. Let me try to do something here.
Is there an instant messaging like chat feature within the
There is no IM. There is a messaging system, but it's not instant messaging. No. So let's try. Let's see. Let's consult intensivist. Start to CNSF. So we've already even built in the urgency of the consult. Because if you go on your own and find an order, you have to change all of this. You have to populate all these fields. We've populated as many as we can. So let me open this consult. So what happens? Order comments, diagnostics, yeah. So consulting physician, TAM, Ben, STAT, CNSS, special instructions. I called Dr. Tam. Because otherwise, it will be tasked to your nurse or clerk to call them. So once you do that, it gets tasked to the nurse and the clerk, and when they open it, they'll see, I already called Dr. Tab, thank you very much, they're not gonna call them. Now, form one. Should we do that? Okay, I'll take silence as yes. So, let's start from the very beginning. A very good place to start. Let's go back, let's close this and go back to our tracker. So I'm going to do a form one of this patient. What I have done, let me reduce this, is I have added ER docs here to my buttons. And in my video about mental health, there's instructions on how to do that. Here, I can do it very quickly. Let's add CNN. Customize, add CNN, HTTPS, CNN.com, or you can copy and paste the address from your browser, close, and now there's a CNN button. There you go. Now, I'm going to open ER Docs, and I'm going to open the mental health. I'm also going to open the patient's chart. Now, here's a nice trick that you might not know in Windows. If you hold this and pull it to the edge, it takes half the screen. Oh, where is that one? Oh, did I close it by mistake? I must have closed it by mistake. Yeah, I must have closed. Shush. ER Docs. Form 142. Why did it crash? It's crashing. I can't believe that. ER Docs. Form 142. This is half, and this is the second half. Now, if you go to ED demographics, this is the patient's demographics, and what you can do very easily is copy, paste. The address, copy, paste, as threatened. Now, here we go. Suicidal ideation with a plan to hang himself, period. Oh, it's because he, it must be connected to the session. Well, let me dictate here. Okay, let's do here. Plans to hang himself when kids go home. Does not contract safety. And print. There you go. And from here, I can actually, there you go, I can print it in Pod C. And here, let me scare them and print it in Pod C. There you go. Now it's gone to Pod C. Okay, how was that? Any thoughts or questions?
All good.
Okay. Yeah, all good. Lovely. What should we do next?
Is there
Let's
a
do
way
discharge and-
to,
Sorry, go ahead.
sorry to interrupt. Is there a way to message, because we were talking about like messaging consultants and the messages that were being sent to the receptionist for consults. Is there a way to message our nurses?
So the way it works is you do a communication order. So the way it flows is these orders. Do you see those? So each one of us has a column of tasks. These are your tasks. For us, for doctors, there are only two things that show up as tasks. Either co-signing, and because I have 17 here, I know that either a nurse or a student made these orders, right? And they can't go into effect until I co-sign them. Now, verbal orders also require co-signature. The only thing is they are executable before you co-sign them, but you still have to co-sign them. So here, let's say I want to co-sign them all. Done. The other thing that shows up in our tasks is reassessments. So whenever a patient is put in for reassessment by the nurse, it's added to the reassessment tab, but also a task shows up next to their name. I don't know of any other way of messaging except an order, a communication order. There is this message center, but it's not synchronous, it's asynchronous, so it's useless for our needs.
Rafi, when you do
Is the
multiple
commu-
sorry.
No,
Go
sorry,
ahead.
I was just wondering, is the communication order in the quick orders? Did I
Absolutely.
miss that?
Well, let's try it. Right click, quick orders. Where is stroke lab? It should be under. So these are ortho supplies, patient care. Here, communication order. Time now, communication order, this supply. So this is an empty communication order. There you go. Modify. And the thing is, this stays in the patient's chart. It's an order, right? Please, or here, what I'm going to do is even better. Please call the patient's family, see if they can pick him up. Period. If not, let me know so we can order OPT, period. Sign. Done. So now the primary nurse of this patient, this shows up in the communication order in her tasks.
Nice. Thanks so much.
Pleasure.
Rafi, if you do multiple reassessments, is the multiple reassessment windows are going to open, or everything
No,
goes?
so what you're doing, good point. Good point. So in this patient, I can do reassessments, and you can dictate them and timestamp them, right? So you can say 17:15, the patient's still having pain, period. I've given him more morphine, period. New paragraph. And then I came back at 1900, I can do 1900, patient's pain has settled, period. CT scan shows a past stone, period.
I think you
Now,
mean you reassessed at 1916, right?
Yeah, it said 1900. It's not perfect, you're right.
Well, then you can't build a you can't build a reassess if you did it within. Can't build a reassess if you did it within an hour and 45, right?
That's true. That's true. Yeah.
I'm just looking out for you.
Yeah, and that's why I won't timestamp it. And then eventually, a personal plan. The patient is being discharged in a stable condition, period. We have discussed stone care and when to return to the emergency department, period. I'm giving you a prescription for Flomax and morphine, period. I'm making a referral to Dr. Dion, who is the radiologist, urologist on call. Save. There you go. So as I'm working, I'm doing all this. My note is not built yet. Right?
So back to the kind of joke that you made. So every time you make a note or reassessment, is not going to be automatically time stamped?
No.
Oh,
No, because
okay.
this is all Scratchpad. It
Okay.
hasn't made it into the text. It only, you can put in whatever you want in it. You can edit it. You can do whatever you want until you create an ED note. So why don't we work on discharging this patient then? That's a good thing. So we're going to discharge the patient. We're going to talk about the stages of discharging a patient. Okay. So if you remember from the video, if you've watched it, there are multiple parts to discharge. The current workflow is that departing the patient is a nursing task. We did not get into changing that. Once we settle in, we'll figure out how differently. You can still send the patient and they can depart them, but departing the patient is a nursing task. But discharging is yours. So discharging includes the discharge order, includes a diagnosis, includes any referrals, includes making your notes, and includes prescriptions. The only two things that we made mandatory is a diagnosis and a discharge order. You can't discharge someone without the discharge order, and you can't send them home without diagnosis. So if you go to ED discharge, it has all the things you can do. However, the only things that are mandatory are a discharge order and a diagnosis. There we go. There's a plus sign. This is also, you won't see in Sandbox if you are, the plus here. If you hit it, you can enter a discharge order. However, you can put a discharge order from anywhere. So I can put discharge. It's an order. Discharge patient. The other thing, if you notice, we have, oh, let me go back here. If you are here, we've made it easy and put it down here for you. It doesn't matter where you get it from. It's still a discharge order. I'm going to do it from here. Discharge, close. My discharge order went here. I'm going to go. Modify details because I'm always, see, it's missing something. Discharge patient, home. Sign. Discharge order is done. Now you need a diagnosis. You need, I've made this to this and chronic, but I want to keep it as this visit. You need two things. You need an acute diagnosis, and you need either a chronic diagnosis or no chronic diagnosis in the chart. You can, if you do this, your problem will be acute and chronic at the same time and solves both issues. But I doubt you want to have your sore throat or pharyngitis as a chronic problem. So chronic is easy. If there are no chronic problems, this guy's got one. Right? But if he doesn't have one, you can add no chronic problems to his thing, and that's it, and you're done. Today's diagnosis is renal colic. Why is it not? Something is not working. It's not working. Ah, it's broken. I am sorry, it's broken. Huh. Did I break something? Something is not working here, right? Let me close the chart and open it again.
Rafi, while you're doing that, I think the point that you brought up earlier, it's going to be medical legally very important here, because given the fact that this software doesn't leave a document trail, time to stamp document trail, if you delay your kind of notes, so medical legally, you cannot rely on them as a...
Absolutely, you're absolutely right. So all the things, the documentation that I made and dictated is not your report, is not your note. This is just a draft. This is just a scratch pad. You have to build your note at the end.
It's a significant difference between the other EMRs that I've worked with.
Yeah, I don't know. I haven't worked in others, so I don't know. But there must be a sign and save. There must be a sign at some point you have to convert your free text into a report and click sign, right?
Yeah, but all the other EMRs, every note that you put there, when it's saved, leaves a timestamp. It's kind of, you create a document.
You say that. I like this better because then I can write shorthand and then fix it. I can change my mind.
Oh, it's more convenient, but medical legally, if you don't finish it at the same time.
Yes.
Yeah.
You're right. I'm not disagreeing with you. You're absolutely right. But so make sure you finish your note.
This same thing is true for like all the consultants that do surgeries and see people and dictate their note 4 months later. And
yeah, exactly. It is not a system problem. It's a practice issue, right? So you need to make sure to finish your note. And what we have done, it's very easy. It's one click, right? You click ED note, it pulls everything, you sign it, and you're done. It's not really that hard. Okay, so we've added, I think I broke it by hitting no chronic problems when the patient had chronic problems. So I have an acute problem, I have a chronic problem, I have a diagnosis and discharge order. You're done. The patient can go home. That's it. The nurse will pick up from there. It'll show up in the tracker. Chloe Smith, it should show discharged. Let me refresh that. Yep, there's a key there. Oh no, it's still registered because she's not registered. These patients are not, because the patient's not registered yet. Oh, discharged, yeah. Discharged, 3 seconds ago. There you go, or 3 minutes ago. Here is your discharge. So this patient is now discharged. The nurses will depart the patient. Now, we still need to give them a prescription, right? So we were still in the discharge here. Now, all the orders that we were searching for that Ryan asked about, we were searching inpatient. And inpatient in the system means within the four walls of the hospital. It doesn't mean admitted. If you switch this to prescriptions, now you're searching the prescriptions. There are some common prescriptions here. Don't use them. These came with the system from the United States. We're gonna fix them in the post-production. We had no time to go through them. So prescriptions, I'm gonna search for something. Let's see, I'm gonna search for morphine. That is a very hard one because there's morphine. So these are all the possible morphines. Look at how many pages I have. Morphine 5 milligram. 5. There you go. Morphine 5 milligram oral capsule. Oral capsule or tablet. And if you click this, it adds it to your it adds it to your favorites. Now, notice there are some things that are done for you. So this is morphine 5, 2 tablets, Q4 hours PRN for pain as needed. This is easy. I think I want to take this one. And now, see how it added up there to my basket? I want to search for Flomax. What was the other name for Flomax? Tamsulosin. Huh? Did I? No.
TA.
How do you spell Tamsulosin?
Tamsulosin.
Tamsulosin. 4 milligram, 1 capsule PO, oral tablet, 1 tablet PO. Okay? Now I have 2. Don't sign. Never sign. Always modify. So these are my prescriptions. They're missing fields. So let's go through them one at a time. This is my morphine. So I want to give them 40 tablets. Now I can add all kinds of things. This is filled already because I picked the one that had this. If I picked the blank one, there would not be any of these. It's 2 tablets, PO, Q4 hours, 40 tablets, no refills. Now you notice they have suggestions up here for you. If you click 30, it should fill 30. Oh no, I already put something in there. Let me take that. If I hit 30, oh, it doesn't work. There you go. 40 tabs. Okay. Refills as needed for pain. When do you start? Substitutions, yes or no? I don't know why they're not always yes. I don't care. Okay. Now, let's move to the other one. Same thing, 30 tablets of this. I don't want to add anything else. Now, notice this. This is send to. I can send it to a printer, and now it's sending to my printer here at home. And it'll print the prescription, right? You can send it to a Microsoft PDF. You don't send it, you not send it, you just call the pharmacy, you can. What you can also do is find the pharmacy. But most importantly, if the patient had a pharmacy already connected to their chart, that will populate first, and you can send it straight to the pharmacy without printing it. I haven't tried to find, I tried pharmacy, there's nothing. The database here is empty. I tried. So these 2 I completed. Sign. He says morphine, he has rash. I don't care. Done. In about 10 seconds, it'll come out of my printer. Sign it, hand it to the patient. It already has, by the way, your name and your CPSO number and everything in there.
Rafi, but we cannot add electronic signature, can we?
So let me go grab it. I think it had a line for signature. If you're sending it to the pharmacy directly, it's electronically authenticated. Oh, prints 2 copies, one for the chart as well. New prescription, here it is, okay. So this is, what's the difference between the two? I don't know there, I have to sit and look at them. But if you can see it, it has a line for signature, don't ask me why. This is how pharmacy designed it, I did not. Okay. Oh, this has the BPMH, things changed, unchanged from their admission, things you stop, so you can put in stop to stop their medications, their home medications as well. Interesting, I did not know that. There you go. I don't know how to do that. The other thing you can do with prescriptions is you can change a medication you gave them in the hospital or their home meds into a prescription. So let's go here and let's go see what this patient has in their medication list. They have all of these, right? So I can take a home med, or I can take a prescribed med, or I can take an order med, right? So benzotropine order. Let me change the benzotropine into a prescription. Right click. Convert to a prescription. Takes it on. How many mils? I don't know. 100 mils. 1 mil IM. Oh, it's the IM injection. That's why. No, anyway. 1 mil IM injection. Yeah, that's hard to prescribe, but that's okay. 1 mil. Okay. Order is assigned. Same thing. I don't have anything missing. Sign. And go into my printer. There you go. Processing. No, it's not yet. Let me refresh it. Yep, prescribed right here. So this is the prescribed medication.
For outpatient follow-ups such as GymRack, PRAC, those kind of things, same old process, right? We don't have to do anything differently here other than a talk.
So we're still putting this together, believe it or not. So I'm going to have a video on referrals. So referrals are different than consults. They are still an order. What's this? This is a referral order. I did something on a video. So anything that you need to send in person, like as a fax, you still need to, and I'll show you what we here. Discharge. Sorry. In the works. Oh God, I'm starting to get tired. Sorry, guys. But yes, so for Fracture Clinic, it's going to be a direct booking from our clerks, and for the rest, really nothing changes. Whatever the process is for that clinic or for that, you're going to have to use it. You just put a referral order. Referral order. So an outpatient is a referral. Let me modify. So let's say, for example, let's say I want to do this. Service. Cardiology. Okay. Reason for referral, for whatever reason. Now, referral type, what was that? I don't care about that. Where do I find them? Oh, referred to. Here is the money. So let's say I want to send them to Cotrex Clinic. There is a huge, I don't know how good the database is here compared to the full one. Let's search for Cotrex. He has 4 practices available, and you got to send him. So you want to send him to his office, right? So this is Albert Niagara. Accept. Sign. Now, the hospital information management system will send that in the background without you having to interfere with it. That's it. You're done.
So
how well it works, I have no idea.
Is that for all the ones where I see Cotrex patient, I say fax chart to Cotrex office, that's what I do instead?
That's all you're supposed to need to do.
Okay.
Now, hospital information management and referral system, and hospital referral system is a huge system. I had nothing to do with it. So it should handle it all in the background. Is it going to work as supposed to? Yeah, we're going to find out very quickly. Okay.
Just a quick
Sorry.
question.
Yes.
Sorry.
Go ahead.
Go ahead,
You
Rob.
can't search medication by their brand name, it's only
No,
the
it's
generic?
only, yeah, it's only scientific names. Only generic.
Rafi, for the consults,
Yes, sir.
is there a system on DCMR to replace our getting the clerk call them and talk them on to them on the phone, or I can
Not
send them
in
a
the
message?
EMR,
here?
no.
No.
Not in the EMR. Now, the only thing left is
Now,
documentation. Yes, go
I
ahead.
assume with consults now, if I've tagged them, this patient is now on their list. So all those orders they used to say, hey, oh, by the way, can you add this, this, and this? Now I don't need to be their resident. I can just tell them that they can add them. Is that a
Yeah, we're supposed to add them to their list. Absolutely. Of course, it does not replace talking to them. It does not replace any of that, right? Okay. Only thing left is documentation. So do you remember this ED note, physician? There's also another thing you can do as a consult or a handoff note. So you can fill this up, do a consult note, and pull all this in a different format, and you're able to print it and fax it or print it and send it. I haven't tried printing because you can't print from this system. I'm still about to find out. I'm going to cancel that. Let me see if I sign and submit. Oh, here you go. I can send it from here. See, consultation. I'm going to send it to, who do we want? Robichaud. There you go. This is his practice. He's here, external office. No, that's Robichaud Jeff. Yeah, this is his outside. This is nurse. Here we go. Robichaud. There you go. And you can send it to him, or you can have him sign it if you want to. But why would you? This is only for students. Now, let me refresh this and see what happened here. I'll tell you, hundreds and hundreds of hours, and there are things I haven't done yet. Clinical documentation. Here it is. That's my note to Robichaud. Author, sent it to Robichaud, last updated, date and timestamp, and this went to Robichaud, to Jeff. I should be able to print this. Yeah, it opens this medical record request. I still don't know how this is set up.
And our billing number is there to go to them directly?
It should be. It should be, because it went in the background that we're done, right?
Yeah.
There's nothing I'm going to be able to do with this. Handoff. Yeah, I don't know what it looks like when it's printed. I have no idea. And now it's HIM's problem. They know my billing number. If they didn't attach it to the document, that's problem. I don't include my, it's my signature is electronic. And they decide what my signature is. So this is that. What else do we need to do? Quick notes, consult, sign on. Okay. Am I missing something?
Just to clarify, for all of the rapid access clinics that we currently fax via printing them off from ER docs, like CRAC, GymRac, Stroke Clinic, do we still have to just go to ER docs and fax that off?
So CRAC is not, as we call it, CRAC, it's actually in their own offices. So if we're going to send it, either you're going to send it something like this, or you're going to print it, you're going to do it from ER docs. I honestly, when this started, I thought ER docs was going to be obsolete. I don't think it's going to be. It's just going to change, and I don't know yet. I honestly have no idea how things are going to work. But like CRAC, because it's their offices, if we print it and fax it, I think that's very reasonable. Although this should be able to send it in the background. The other thing is the stuff in the hospital. It should be all through the hospital management system, through the appointment management system. But let's try something. Let's see, GymRac. What do we have? So, there's a return to GymRac, and there is Jimrack Rabbit assessment referral. Let's take a look at return to Jimrack. What does that mean? I haven't done it before. Let's see what it says. Missing. Okay, here you go. So, but it doesn't have Niagara Falls. Interesting. I love this. See, we did not do this, right? We did not build this. So I can say returning to request date, order for future visit, yes or no. I don't know, appointment type, Jimrack follow-up 2015. Oh, that must be the request for the appointment. I guess, I don't know. We'll send their Jimrack and then we'll see what happens. Now, this is Jimrack, we built this, yeah. This is the ED St. Catherine's. What does it have? Oh, this is a replacement for their orders, okay. Okay. Let's see what these are. Come on. Okay, how do I read this? Please draw labs, please, I don't know, okay. Here, it's a referral order to internal medicine. Orders for signature. Here it is. One missing. General internal medicine region for referral. I don't know. I'll be honest with you, I have no idea how we're going to refer to Jimrack. I'll have to ask that question. Okay, let me put that down on my list.
How
Amazing.
about EPAC, Rafi?
I have no idea. Let's try. I think we did EPAC because I think I remember testing it at some point. Early pregnancy assessment. Here you go. Referral. Modify. I remember testing this. There you go. Yep, here it is. Communication orders. There you go. An ultrasound. So you have two to be performed weekly during business days or return to EPAC to be as regular ultrasound operating hours. Next day. There you go. Same day or next day. Next day. See, this we fill this for you. Okay. Priority, no. Urgent. EPAC. CC provider. Sign orders. There you go. And sign. That's EPAC. What else can you think of? Let's look for them.
ED interim admissions.
Oh, these are easy. ED interim admissions. There you go. Open it. Modify. We built that. There you go. ED transfer, same site, different site. MPO. I'll tell you, you reminded me of something. Okay. I need to, we'll talk about a PAO, a patient admission order. Okay. Oxygen therapy, peripheral IV. See, that's MPO. You can document the code status. MPO. Activity is tolerated. Height and weight. O2. Sodium chloride. I don't want, just want an infusion. Sodium chloride. 75 an hour is good. Smoking cessation. You can pick option 1, 2. Here we go. 121. Nicotine PRN. Inhalation. Return. VTE prophylaxis. General. Not indicated. Sequential compression. There's still somebody has sequential compression still. Really? This is 40. There you go.
This is admission?
No, this is interim admission orders.
Interim.
Yeah. I want to give it some Tylenol. Any other labs that we want to do. Any other CTs we want to do. Any ECG if we want to do it. Notice we've picked the right ECG for you. This is the ECG by nursing CV, which is the right one in the ED. Otherwise, it won't get tasked to the nurse. Okay. Consult pharmacy for BPMH. Okay. Who do I admit to though? Where is the order? Where is the PAO? There should be a PAO, which is a physician. Let's see if it shows up after orders for signature. Oh, this is the goals of care. Good, that came up. This is the goals of care documentation, R1, R2, R3, and which each one's means. So this is Medicare Care 1 by the patient. Active dispute resolution, no. And sign. So I've just documented goals of care. ECG by nursing is going to ask me for this. Who cares? I always type other. I have no idea why they ask me these questions. Now, this patient, there's no admission order. Or there's a duplicate. What is that? Wait. Remove. Good enough. And that's done. Now, PAO. So a PAO is a single line, a single order that starts the process of admitting the patient. It's one order. We'll use it only in two situations. The first is if we are admitting to another service and we want to initiate the care. So for example, I speak to Ben Tam in the ICU and he says, you know what? Great, just put a PAO in, send him up, I'll see him. You don't need to, I don't want you to write any other orders, right? It's just the PAO. Also, the PAO is important if you're going to do GYNAC or PARC. Now, God love GYNAC, I never can get them to see anybody. It's a little bit easier, not much easier with the pediatric CDU. These are called outpatient in a bed. They are also a PAO. And the important why you want to do a PAO, because if you discharge the patient and register him somewhere else, these are two different encounters, and the data and the orders will not flow from one to the other. So let's do a PAO. Is it a PAO or is it admission? Is it patient admission? I haven't done it before, so. Patient admission order, this one, PAO. Patient admission order. Why are there two? Admit order. Let me see which one this is. Admit to inpatient. Ah, there you go. Outpatient unit. There, this is the one. So this is to an inpatient unit, or you can do an outpatient in a bed. And I'm going to do outpatient in a bed for you. Initiate now or later. Initiate now. Orders for signature. 4 missing requirements. Which one is it? So it's going to be pediatric. This is for pediatric CDU. The provider is, who is pediatric core? She show up? Yep. Medical service pediatrics, because GYNAC would be obstetrics. Request a best assignment. Yes. So this is an outpatient to a bed. This is the order for GYNAC and pediatric CDU. Patient admit. What's the difference? What are these? Let me take a look. Are they any different? Oh, it's the same one. They just have two different names. This is when you admit to an inpatient, and you can plan it for later or for now. Initiate now. Patient already been admission order placed. Cancel, admit to hospital, continue ordering admit. Yeah, we don't care. It's not a real patient. He's telling me you've already admitted him. Why are you admitting him again? Orders for signature. 3 missing requirements. Same story. So we're going to admit him to cardiology. Kim. Multiple. H. There you go. Level of care. We're going to do tele. All right, where is tele? Telemetry ward. Yes. And any special instructions that we have. Sign. Telemetry ordering set, level of care telemetry, but the clinical telemetry monitoring must be placed on this patient. Okay, sure. Telemetry monitoring. Admission criteria, syncope. Sign. So he'll tell me if there's something missing. There we go. Done. Okay, PAO, let me write that again, referrals and PAOs. Okay, I gotta do something on that. What else do we have?
And does fracture clinic work the same way?
So fracture clinic, they're gonna be, I'm gonna do a whole video on fracture clinic. I still haven't gone through the workflow with them because the difference for fracture and plastics will follow is we're gonna book them straight into the clinic. So there's no more stickers. You put the order in, the clerk or the nurse books it. It comes out with the patient's discharge instructions, prints by the nurse, and done.
Fracture hip order set, admission order set.
So don't do that because then you will be filling the orthopedic fracture. I always do interim orders. I'm sure there is. Hip fracture. There you go. Surgical ortho hip fracture order set. However, I bet you it's 700 pages long. And it commits you to all kinds of things that you don't want to commit to. So anytime you're doing, where is this? Initiate care path. Okay, let me try. Let me see what happens. Oh, here you go. Preoperative. See how long it is? See how many pages it is? So don't go there. Even if you're
Yeah,
gonna
I'm with
admit-
you, Rafi. We better not even get there.
I'm sorry?
I agree with you. We better not even get there.
So just do ED interim, admission order and transfer. There you go. Oh, I took it off, sorry.
I hesitate to even utter these words. But what does workflow for a code on the floor look like?
So I don't know. I have no idea.
Because that's going to be us too, right?
Yeah, so Code Blue people did it. I heard a while ago that Code Blue is staying on paper.
Oh.
But I'm not sure. We're gonna get there, we're gonna shout orders, and we're gonna see what happens.
Okay.
I think it's staying on paper. Code Blues are after implementation.
But if I have a code blue on my first shift after this, I just go up to where the code blue is and yell orders.
Let's figure it out. Yeah.
Okay, cool.
That's
I can do that.
Yeah.
But probably got to bring your computer though, right? If you can.
I guess if you can, but if it's I have no idea. I don't know. I'm not part of the Code Blue. I don't know. Pam, do you know by any chance, or is Pam still on, or no?
She left.
Okay. What else? Discharge. So I have not used it yet. Yeah, lose them. Okay. But remember when we had the ED discharge, there's an ED admit. Same thing. You need an order profile out of this house. So when you go to ED admit, same thing. You have all the stuff that you need, but it includes the order profile where you need to put in admission. There you see, admit the patient, it's here. Wow, look at that. Look at all these orders. Somebody's gonna have to do them. Okay. We created all the 3 notes, we discharged, we admitted. Oh, chemical restraints. So chemical restraints are an issue. Even though what we did with ED mental health, we just did one of those. It's called an admission transfer. Don't ask me why. There's an adult and a pediatric one. We'll do the adult one just because it's more comprehensive. You know what I'm going to do? I'm going to go into a new patient because it's going to do 100 errors for me. Let's try this. And did you notice it doesn't matter where I search for the order is? Same thing. Like I can search for it from here in quick orders. And it's probably here somewhere. But here, ED mental health. But if not, I can just search for it here. ED mental health. Oh, we did the adult one. Let me show you the pediatric one. So the pediatric one, don't sign, modify, is much shorter and smaller. It's easier. It's probably for, probably under 12 or 13. More than that, you probably have to. But what I want to do, I'm going to cancel this. Okay. I'm going to show you, not that I want you to do it, but you can also search for orders from the order tab. See this familiar place here, right? If you put add, some common orders, but if we say chemical restraints, there we go. Close it. So this is my chemical restraints. Now, the trick with chemical restraints is the difference between chemical restraints and sedation or agitation treatment is really consent. So if you put them just as agitation orders, the patient can refuse to take them. So chemical restraints are put in as a separate order, either to be initiated now, or they're put in an order where the nurse can initiate them. Our policies are a bit not accurate, and they don't differentiate between mental health and non-mental health, which they should, because they're two different acts. But this solves the problem. So I'm going to order this chemical restraint on this patient, but I'm going to put them as I'm going to initiate them for later. So usually what I use is 2 milligrams of lorazepam. Haloperidol, I usually use 10 IM. There are all kinds of other options, but I don't want them. All I want to do is give them benzentropine if they need it. So this is my go-to 3 drugs. Instead of hitting initiate now, I'm going to plan it for later. Go through the same process, sign it, and I'm done. What I'm going to do, though, is I'm going to show you what happens on the nursing end. Which patient is this? Barist 5 radiologist who's sitting in A16. I am going to exit, and I closed the whole thing. It's okay. Give me a minute. I just have to re-log in. And I'm going to log in as a nurse and show you what happens. Cert domain. I'm going to open a FirstNet cert. This is without Dragon. This is DMO is Dragon. Dragon Medical 1 is DMO. Let me see. NHS EDRN01. No. EDRN, I think so. Yes, I got it. Okay. Orange risk nephew. What is this? I have no idea what this nephew scored is. Okay, discernible. We should do you want to do still a sepsis alert?
We should probably do sepsis alert.
Oh,
We should
yeah.
probably do, because it will stop you in your track. If a patient satisfies, so this exam 5 satisfies sepsis alert, it won't let you move until you deal with it. Okay. So where was the patient in A, the one what we were talking about? A3? No, this is OBS. Oh, this is because it's Niagara Falls. Okay, check out. I'm gonna check in and let me go. ED nurse. Oh, St. Catharines. Where's Niagara Falls? Niagara Falls site. Niagara Falls. Oh, come on. Niagara Falls ED. What is it called? It's that emergency. Okay, and change location. Oh, it's Welland, St. Catharines. Okay. So this nurse is now in St. Catharines, and it was A3, this guy, right? That we ordered it on? I'm pretty sure.
Yep.
So if you go to this guy's, we're gonna do a few things. First, let's go to this guy's medications. We have this view. Oh, I have ordered them from before. Oh, midazolam. The new order is not here in their medication. If you go to orders, it should be sitting under chemical restraint. Who initiated that? Is it somebody else? Is that someone else? Did we do it on this guy? It was radiologist. Oh, this guy. No, we did it on this guy. Sorry. So if we look at this guy's medication list, the orders that we placed for chemical restraints are not there. If we go to their MARs, now we don't have a MAR view. They're not there. They are sitting in orders under planned, but not initiated. And when the nurse wants to enact them, they will go to initiate now. They will pick up the reason initial plan. This is why I came in as a nurse, because that wouldn't show me that. It'll know that I am the signing physician. Just let me initiate it. Orders for signature. And the nurse will sign. And now, if I go to the MARS, let me refresh. There you go. You have a stat order for haloperidol and for lorazepam. Now, let's hope that this nurse has not, let me try to open this guy. No, because it is suppressed. This guy, suppressed. Okay. Let me go back. Let me exit and log in as me again. No, no power chart. I don't want power chart. Exit. Exit. I want first net. Open. Okay, so there is no more adult sepsis order set. It's gone. There is a pediatric one because the sepsis alert does not work on peds. It's only for adults, but there is no more sepsis alert for sepsis order set for adults. What's my password? Done. What happens is whenever a patient satisfies sepsis or septic shock or severe sepsis, and they, like, as it progresses, it starts again, they will be read, and what will happen is if you try to open the chart, the sepsis advisor will pop up. Now, if you want to initiate an order set or it pops up, this is what it's going to look like. It's an order just like anything else, so you can find it by saying sepsis advisor. So you want to treat someone with sepsis. And this is what it will look like. It just opened. Now, I'm not able to show you the sepsis alert. Please go see it in the video, because all of these I've opened their sepsis alerts and they have been suppressed. So this is the sepsis advisor. 3 stages: evaluate, select, and document and sign. This patient has SIRS criteria. The recommendations will change depending on which level the sepsis is. I'll pick septic shock, so it'll give me, in this case, to show you inotropes. Septic shock, and then you go into some history of the patient. It'll give you some encounters, results in past 72 hours, any recent antibiotics that have been given, some microbiology results, vitals, and then it'll ask you, what do you think the source of the infection is? So let's pick, for example, intra-abdominal source, peritonitis or secondary peritonitis. Okay, so this is peritonitis. And you can pick another, so you can use, for example, urosepsis. Now we're going to ask him for recommendations, and what we'll do, it will recommend to us, this is the current antibiotic that he has. Select any active antibiotics to be canceled. So I want to cancel his Zithromax. You can pick, if you're giving a normal dose, renal adjustment, dialysis adjustment. We're always going to go with the ED single dose. It's easy for us. And these are the options. Option A is ceftriaxone, 2-tetracycline. You can do ertapenem, you can do meropenem, you can do ciprofloxacin. You can decide to add Vanco. Okay, so what I'm going to do in this guy is I'm going to, for yours, I'm going to use ceftriaxone, 2 grams IV. For the intra-abdominal, he's not recommending coverage with metronidazole. Oh, beta-lactam if you want to add, no. Oh, this is another option, ceftriaxone or metronidazole, there you go, or ceftriaxone. I could just choose this one instead, because it covers both. And turn this off. Oh, it's the same one. I'll clear it. There you go. So I picked this one. It has multiple boluses. They're all small. They haven't changed them. While you can change them after the fact, my 2 liters are very easy. I give them a liter of this and a liter of this. Lactate and sodium, that's 2 liters. And then I can maintain them on. This is 125 an hour. I want O2, I want Foley. I want a peripheral IV. I want the second IV. I want an ECG. If I want any of those, his lab's already done in Emerge. I want to put them on NorEpi. I'm going to confirm my orders. These are a list of the orders I did. These are suspected infection sources, what I use for drugs, fluids, oxygen therapy, etc. NorEpi. I'm going to add septic shock to his diagnosis list. That will automatically be added. I'm going to sign the orders. Goal of O2 is over 92 in this guy. I have a few things missing. Let's go through them. Catheter external. I don't know what that is. I have no idea. I don't know who put it in there. Starting dose for NorEpi. Let's say 5. There's a range already put in the instructions. Reason for procedure, ECG, who cares? One day I'll be able to take all these yellow things out. Sign. It's an error in this database. He says there's an incompatibility. Who cares? Saline and D5W. Somebody else's problem. And I'm done. And remember those things here. I'm going to create an ED physician note. Here's my note. Let me show you tagging. You can add labs, do not add to the note. But if there are any results, you can tag them. Or you can tag old reports. Let's see, are there any labs here? No, there are no labs for me to tag. You can go to clinical documentation and you can pick up an old note. So my anesthesia here, can I tag it? I should be able to tag it. Right click. No. Oh, apparently I can't tag it. I was wrong.
Let's try medication, maybe.
Medications, I don't think you can tag medications because they come up already. Things you've prescribed, I think, come up. Anyway, labs are the big thing. Wait a minute, there was somewhere here. I gotta find it. Where's clinical documentation? Let me open this. Let me open this here. Select that. Ah, here it is. There you go. So I can tag whatever I want. Tag. Let's see what happens to that. I'm going to now create my note. And here is under procedures. Here is my tagged. No, where did it go? It was somewhere. Yeah, it is this one. It's tagged here. Nope. I have no idea where it is. Oh, here it is. It tags text. Here it is. It's attached to it. And if I want to send it to somebody, I don't know. Let's send it to Raphael. Bob, here you are. Okay. Sign. Now, this will go to you in your messaging box, in your message. Now, there's one thing I want to tell you guys. I'm going to email the whole group. So I went to my favorites fair today, and the favorites fair has nothing to do with emergency medicine and what we do. They did not account for what we do. So I took a picture of their actual. This is their worksheet. Here, let me bring it here. Oh, let's see if I can do that. Can you see the picture? Can you see the Monarch picture, or are you still
Yes,
stuck
we
on it?
can.
Oh, okay, great. So there are a lot of things. So patients lists are not for us. We don't care. Prescriber handoff, we don't care. Care teams, we don't care. Ambulatory organizer, we don't care. Order sets, we've already talked about. M-Page, yes. Order profile, that's quick orders. M-Page views, we already talked about them. reorder, we don't care, drug and access, we care. So there's several of these that we don't use. So if they start teaching you, just tell them we don't care. Just don't teach me patient lists. It's not a part of our workflow. Okay. Guys, we have done a lot today.
Yeah, I think we should stop and then.
Yes.
Thank you very
I
much.
don't think I have anything else to say. You've learned everything I know.
Thank you very much. That was very helpful.
Thank you, Rafi.
Thanks, Rafi.
Okay.
Thanks,
That's
Rafi.
great.
Thanks,
Yeah,
Rafi. Appreciate it.
My pleasure. So second thing is what you're gonna do. So practice. You can do most of these in the sandbox. I'll publish this on my YouTube channel. I won't put it. I'll see if it's good enough. I'll publish it so that at least you can go back and try to replicate some of the things we did. Because to be honest, when you start clicking, it's very different. You'll feel lost.
Mhm.
I feel bad that the screen control did not work as well as I thought it would. Okay, everyone. Any last burning questions?
Oh, good. Was wonderful. Thank you.
Yeah, very good. Thank you.
Okay.
Thanks a lot.
Oh, I gotta go. I have 14 charts to dictate. Take care, guys.
Bye-bye.
Bye-bye.